forget about the skincare, because the skincare of the patient is actually very important. We tend to neglect underneath that cannula, and then the tape is actually causing pressure as well. So it should be done on a daily basis. And if you actually need to ask for the dermatologist to come and have a look, if in case the patient is starting to have a rash, it will be a very good idea, and it will be quite evident during the first few days of the PDT being inserted in situ. H is for humidification. You have to keep secretions loose. There is a humidification lather that we use in the United Kingdom. And this is something I'm going to discuss in the next slide. We should also be involving the physiotherapist in planning and looking after this patient.
Your time is 5 minutes left, Ms. Lynn.
Sure. Thank you. So humidification, secretions, environment, you just have to make sure that it's actually well looked after. Mouth care as well is very important. Please do not forget oral hygiene, because it helps keeps the patient's lips, and they're a lot more comfortable when it comes to it. The last one would be swallowing and nutrition, because for SLT, you need to be able to assess speech and language only if you are trained to do so. You need to get a qualified professional to be able to do this. All right. So for humidification, just something to remember really, when we are using humidification, saline or hypertonic saline nebulizers are actually going to be used. We could use, sometimes we use 3%. When we're adding it, just to keep it very dry and to keep the secretions loose, so it's easier for the patient to expectorate, and it's easier for the nurses to actually suction it. The tracheostomy care record, especially in the community setting, is very, very important. It has to be easily accessible. If it is placed by the right-hand side of the patient, it has to be on the right-hand side of the patient all the time, unless it's being used. Because in case of an emergency, the tracheostomy comes out, you need to get that, and you need to be able to get the right equipment that you're going to use for the changing. It should also contain the plans for deflation, any need for physiotherapies, and please do not forget that it's very important that the patient is actually nourished, because if the patient is not nourished, then healing is going to be impaired. So the patient might have a PEG, the patient might be on TPN. It all depends on what the consultants and the rest of the MDT team would actually decide on. You need to avoid hazards. This is now specifically for patients who can look after themselves in the community. Loose-fitting neck clothing for easy access. You need to use, or the patients would have to use commercial coverings for the tubes, because it actually does prevent anything foreign to be able to come in. Some patients do like using scarves, but it's not really recommended because it doesn't have that filter or that barrier that actually helps prevent anything from going in. The same with water. You can't get water into that tube, again, for breathing, as well as swimming or other contact sports. So it's a big, big no-no. Talcums, aerosols, animals with fine hair, really, and in changes in temperature or climate as well. And of course, there's an increased risk of infection. As soon as you go with an open port, it's going to ask for everything that it can find. The patients who are discharged in the community should have a spare tracheostomy, same size, smaller size, just in case it comes out. The patient would always have to bring this bag with them wherever they go. They might be in the mall doing some shopping. They might be in church for a mosque. They need to have this just for safety reasons as well. And make sure you have a very good cleaning brush, because it's a lot easier if the secretions are actually soft. It's so easy to let it come out. So that's one thing that we should all be remembering, really. There's a few optional items, but this is for someone who's actually very good in delivering the service in the community setting. But a suction is very, very important, because this is the only way sometimes that you can get the thick secretions out. And in case of an emergency, this is your first equipment that you would be reaching out for. just making sure that they're all in place. You have a spare inner cannula. Inflation should be checked as well. And it's very important that you inform the electricity board or whoever your electricity provider that one or two family members is actually dependent for breathing or for life measures with that machine. So everybody could have no electricity, but you can be assured that you do have electricity continuously. And yes, thank you so much for having me today. If you do have any questions, please feel free to email me on lynn.arenas@visithealth.gov.uk. Thank you.
Okay, thank you very much, Ms. Lynn, for your detailed and very clear explanations. And let me give some key points from your slide. Caring patient with the PDT in home care. I have the formula from Mrs. Lynn, like track, hack, and MS, like that's a tube care. Then caring of the modification and swallow and from abbreviation from the track, hack, and MS. That I think very clear explanation from Ms. Lynn. Okay, now I think time is for our discussion today in webinar. Now we are in a question and answer session. Our speakers here will answer some of your questions that collected before and during this webinar. And due to the limited time, we apologize that we can answer all of those questions. Okay, I think now we have some questions for speakers. There is the question here from Indonesia for Miss Astuti, Ibu Tri Astuti.
Yes.
This is from
I'm here.
From Depok. The question is, Ibu Tuti.
Yes, I am.
There is a question for you. How care the dressing care and cannula tracheostomy?
Yes.
I think,
Ya, untuk perawatan tracheostomy itu prinsipnya harus bersih. Luka stoma itu harus bersih dan kering. Jadi tidak setiap luka stoma itu ditutup dengan dressing, dengan kasa. Jadi kita lihat dulu apakah dressing itu dibutuhkan. Dibutuhkan bila ada jika perdarahan, perlu adanya dressing yang tebal untuk mengedep perdarahan. Yang kedua, apakah skrat itu ada suatu purulen ya. Jadi kalau purulen itu mungkin ada infeksi ya. Jadi kita harus perhatikan perdarahan karena luka baru atau perdarahan karena luka lama. Nah, kalau luka baru tentunya pada saat pasca PDT itu ada luka baru. Mungkin perdarahan masih berlangsung 1 hari sampai paling lama 3 hari. Itu kita lakukan penutupan stoma. Tetapi ketika pasien sudah tidak ada perdarahan, itu kita akan lepas, dibiarkan terbuka tiap shift kita atau setiap hari kita lakukan pembersihan. Prinsipnya bersih dan luka stoma bersih dan kering. Nah, itu nanti bila kalau ada suatu pengeluaran pus, itu kita bersihkan dan kita berikan antibiotik untuk antibiotik salep ya. atau diberikan oleh medis untuk pemberian obat-obat suntikan untuk antibiotik. Itu aja.
Okay. Thank you, Ibu Stuti, for the answer. The principle is for the caring for the stoma of the tracheostomy is clean and dry. Is that right?
Yes.
Yeah.
Yeah.
Yeah, because sometimes it could be there is a hose or bleeding is could be come up from that. So we need to be more caring for that, aware with that.
Yeah.
Thank you, Ibu Stuti.
Yeah.
And the next is you welcome. And the
Yeah.
next question is for Dr. Lindy. Hello, Dr. Lindy.
Hi.
This is the question from Erwin Widodo from Malang, Indonesia. This is Java. The question is how to minimize the aerosol generating procedure in pediatric with the trachea cannula suctioning.
Okay. I think the recommendation from the guideline is to do an inline suctioning. That means a closed suctioning if possible. If the patient is connected to the ventilator, inline closed suctioning will be recommended. That will prevent the aerosol. If your patient is on weaning itself, where it's not possible to have the closed suction in a sense, you could put a trachea mask where you will connect. I think you will connect the inline during your suctioning, because that is when you generate the cough that the aerosol happens. So, the simulated studies have shown that it's during the cough and the aggressive cough that's where the aerosols are generated. So you could have a cover over while you're doing it, or you can have something like the plastic sheet that I have shared in my slides, where you can have something like the plastic sheet over when you're performing your suctioning. That could be something to prevent the aerosol to the healthcare workers. But most important, the healthcare workers should have on an N95 and a face shield while they're performing their suctioning.
Okay, thank you very much, Dr. Lindy, for your answer to the question. I will speak in Bahasa. So the answer is from Dr. Lindy. Yang paling penting pada perawatan pasien tracheostomy untuk mencegah terjadinya aerosol pada pasien pediatrik adalah penggunaan suctioning yang closed suction. Terus penggunaan masker, N95 itu the most important thing. Facial itu juga sangat penting. Dan penggunaan plastik kayak apa tadi yang sudah dia contohkan dalam slide-nya nanti bisa di-share. Okay, I think that's all. Now I'm going to, there is some question for Mrs. Lin. To Mr. Lin, there is a question. This is question is, how is the best tracheostomy treatment technique for COVID patient, both of the frequency per day and prevention of the aerosol?
Sorry, would you kindly just repeat that for me, please?
All right, yeah. Yes. The question is, how is the best tracheostomy treatment technique for COVID patients in frequency per day and for the prevention of aerosol?
Okay. It actually is not anything different bedside, but the recommendation that it has to be performed in a negative pressure room. We would not want to do it in an open area. I know, like our ITU, we do have like 4 beds in ITU standing side by side. But then for this procedure, it is really mandatory that it's actually done in an area wherein it is negative pressure, as I explained earlier on, so that any contaminated air is actually not going to be able to escape out, and anything that's actually going to be a risk for the patient is actually minimized as well. So it would still be the same. And with the aerosol, you have to require a bit more sophisticated PPE, like what Dr. Lindy Tan actually explained earlier on. It would still be about the same, but it's going to be different if the patient is actually the one who's looking after their tracheostomy in their home place, in their usual place of residence. So since there are no patient or no other people that can actually have the infection or be contaminated, there's actually no need for that if they are in their own home setting. Thank you.
Thank you very much, Ms. Lim, for the answer. Question. Next question actually from, I'm sorry, I forgot the name, from Anggia from Malang. The next question is to Mr. Aib. Mr. Aib, this is the questions in Bahasa from Ida Saida from Garut. The question is pencegahan infeksi nosokomia pada pasien COVID-19 dengan tracheostomy.
Ya, terima kasih pertanyaannya dari Garut. Thank you for question. Untuk pencegahan pada pasien tracheostomy, pada pasien yang dilakukan tracheostomy pada pasien COVID, tentunya tadi saya sudah jelaskan. Pertama, tetap menggunakan APD lengkap, overall, kacamata, kemudian Google, sepatu dan yang lainnya terus lengkap. Kemudian yang lainnya adalah section close dengan menggunakan close section, kemudian manajemen cup pressure, dipastikan tekanannya sesuai, tidak bocor. Pap dengan satu jalur atau menggunakan sirkuit satu jalur juga yang menggunakan HMA, direkomendasikan seperti itu. Kemudian tentunya ruangan di ruangan yang tekanan negatif. Kemudian pasien yang dilakukan tracheostomy itu pasiennya dipakaikan masker, apalagi pada saat dilakukan breathing circuit trial. Nah itu balonnya kan mulai dikempeskan, pasiennya digunakan masker agar aerosolnya diminimize, agar berkurang gitu. Kemudian untuk inner canul juga sama, penggantiannya jangan terlalu sering. Saat memang dibutuhkan sekali baru dilakukan perawatan inner canul. Kalau tidak perlu jangan, sekali-sekali untuk membukanya. Kemudian untuk sama dressing juga tidak perlu. Jika terjadi infeksi baru kita lakukan perawatan dressing atau perawatan lukanya. Begitu mungkin Bu Kias. Thank you. Hello.
Thank you very much, Dr. Ai, for the clear answering.
Terima kasih.
The next question is, I think this is for Ibu Tuti. This is from Chocho. From Chocho is from Yangon. I think this is Vietnam, yeah? This is coming from Vietnam. Yeah. How long can tracheostomy place in the trachea? Very simple.
Tidak ada tracheostomy, penggantian tracheostomy itu tidak ada rekomendasinya bahwa kapan bisa dicabut ya atau bisa dikeluarkan. Tapi ada menurut literatur yang ada pabrikan mengatakan bisa 1 sampai 2 bulan. Tapi kalau di kita di RSPAD itu ada bulan untuk kemampuan pasien untuk batuk, napas dan bicara. Nah itu kalau sudah ada batuk, napas dan bicara itu udah baik, itu kita dekanulasi. Tapi kalau belum baik, kita ganti dengan ukuran yang lebih kecil di bawah ukuran yang kanul sebelumnya. Itu yang direkomendasikan oleh pabrikan, atau kita membuat SOP penggantian kanul seperti itu. Terus kemudian dekanulasi bisa saja bisa terlepas sendirinya karena beberapa hal. Tapi dekanulasi yang secara terencana itu dibuat SOP bagi rumah sakit RSPAD adalah 1 bulan sekali untuk evaluasi kemampuan pasien untuk menelan, kemampuan pasien untuk batuk, kemampuan pasien untuk bernapas secara spontan seperti fisiologis pasien napas melalui orofaring dan hidung. Itu situ aja cukup.
Okay, thank you, Mr. Astuti, for the answer. But let me to translate to the Coco from the Vietnam Yangon. The answer from Ibu Astuti is actually there is no recommended the time when exactly for the decanalizations of the tracheostomy canal.
Yeah.
But it depends on every hospital is about have the standard operating procedure.
Yeah.
It can have different And then secondly, we have to look also the patient if the patient have the patient operating adequate, like spontaneously, and then get coughing, and then get breath, and then swallow very good. I think that's one of the criteria the patient can do the decanalization. But every hospital must be different. Also in your country must be different. In her experience of the Tuti in the hospital in Gatot, they have the standard operating procedure is about 1 to 1 month decanalization. I think that's all.
Thank you. Thank you.
There is another question again. This is for Dr. Lindy. Dr. Lindy, there is a question for you. The question is how to management the airway, like a suctioning, nebulizer, bronchial washing, etc. from the patient using trachea cannula in the pandemic COVID-19 like this at this moment with the minimized aerosol for safety medical team. That's question from Ayunita Malang.
Okay, thank you. Thank you for the question. To prevent aerosol, is recommended for humidification, we use the HME. But you need to note that using the HME, you do have incidents, or you can run into incidents where the tube can get encrusted with secretions, because without the humidification, the water humidification is better than the HME. But to prevent the aerosol, we do recommend that HME is being used, but you need to evaluate. For the routine changing of the inner cannula, we do not recommend. You will have to assess the patient's need and do it when it's necessary rather than a routine. And for the nebulization, we recommend using the MDI. In the inline suctioning, usually sometimes they have a port. For the Portex, they do have a port where you have the orange port where you can actually do the MDI rather than you do the aerosol type of nebulizing. Then for the suction, we still recommend inline suction as a choice if you could have it. I know that in COVID-19, resources are scarce and we do have limits. So our hospital policy is we change the tubes per patient use. or when it's necessary. We do not routinely change like what has been the used to be, where you will